Hi there, my name's Dr. Brian Lipworth from the Scottish Centre for Respiratory Research, Ninemores Hospital, University of Dundee. It gives me great pleasure to give you a taster of our review article that we published 2 days ago online in Allergy. Just as a preamble, this is a concept which I call the type 2 cytokine bucket, where you have the 3 leaky holes where you get escape of type 2 mucosal downstream cytokines, namely IL-4, 5 and 13, which can be blocked by the various biologics, which you can see there. And then you have the upstream epithelial alarmin cytokine tap, which drips and fills the bucket, and those are either TSLP or IL-33. And that's what drives the patient phenotype in terms of exacerbation symptoms, airflow obstruction, corticosteroid sparing, airway hyperresponsiveness, mucus plugs, and of course airway remodeling. So the methodology is that we appraised all the studies where there were head-to-head indirect data analysis in adults with refractory asthma, and these focused on clinical outcomes, including rate ratios and confidence intervals. And so by definition, if you're comparing drug A versus drug B, then a 95% confidence interval for the rate ratio, excluding unity, denoted a significant difference. We did these head-to-head comparisons for other endpoints as well, but I'm just going to focus on exacerbations and steroid sparing here within the limited time. Just to make this clear, this was not intended to be a systemic review or meta-analysis, although we did create forest plots. There was no assessment of weighting or heterogeneity, or indeed a pooled analysis, because we didn't think that was appropriate. So this slide looks at the annualized exacerbation rate overall, irrespective of phenotype, in terms of biomarkers like eosinophils and FeNO. And what you can see here is that the red estimates for the rate ratio are the ones that significantly exclude unity there, whereas the black ones, they cross the unity line, and therefore those pairwise comparisons are not significant. From that, you can see that dupilumab has superior effects in terms of reducing annualized exacerbations compared to the anti-IL-5 drugs, mepolizumab and benralizumab. And in that regard, that's perhaps not surprising, because the anti-IL-5 drugs are rather a narrow spectrum. They only impact eosinophils in terms of blocking the leakage from that IL-5 hole, whereas dupilumab blocks 413, suppressing FeNO and IgE. And although it doesn't have any effect in terms of suppressing blood eosinophils, what it does is it prevents the trafficking of eosinophils from the blood into the tissue, which is why you can actually get a transient rise in eosinophils with dupilumab. The other thing we found was that not only dupilumab was superior to anti-IL-5, but tezepelumab as well. Again, no surprise there, because although it's working upstream, it does block downstream expression of IL-4, 5 and 13. And if we look according to those patients with an eosinophil count of more than 300 cells per microliter, again, we saw there that even in this subgroup, that both dupilumab and tezepelumab were superior to anti-IL-5 in terms of benralizumab. You might think that's surprising, because of course benralizumab totally depletes blood and tissue eosinophils, but that's what the pairwise analysis showed in our study. And if you want to read more about that, you'll have to read the article to look at the critique. Oral corticosteroid sparing, here there were only 3 studies, and in these 3 studies, dupilumab was superior to either anti-IL-5 as benralizumab or mepolizumab, or anti-IgE as omalizumab. So thank you very much for watching my short video. And again, if you want to look at other endpoints like lung function, ACQ score, quality of life, airway hyperresponsiveness, small airways dysfunction, please do read the paper in more detail. And there you'll find an interesting critique as well. Thank you very much.